Are you being challenged while administering analgesia to not over or underdose your patients? It's time to eliminate the guesswork and accurately measure your patient's nociception level in the OR and the ICU. Join Dr. Adrian Wong, Dr. Sean Kucklenberg, Rachel Weisbrod for an interactive live panel discussion 15th of April at 7 p.m. CET, in which you can pose questions and share your feedback about the main challenges of intraoperative nociception, its complications, and our solution. Is customized analgesia the new science of the decade? Join us now. For more information, follow the Pain Talk hashtag.
Right, hello everyone, and welcome to this what will be a very interesting live discussion on the management of intraoperative nociception. My name is Dr. Adrian Wong. I'm a consultant anesthesiologist as well as an intensive care consultant at King's College London, and I'm joined today by two expert colleagues, Sean and Rachel, who will now introduce themselves. Sean?
Hi, my name is Sean Kucklenberg. I'm currently specializing at the University of Brussels, and I'm spending a year at the University of Ghent. And I've had a little bit of experience with the Null Index and other monitors, and I'm really happy today to spend a little time with you and Adrian, Rachel, to discuss this.
Rachel?
Hi everybody. Yes, I'm Rachel Weisbrod. I lead clinical, regulatory and quality for Medesense Biometrics. Medesense Biometrics is a company based in Israel that has developed and is now introducing the Null Index for the monitoring of nociception. So delighted to be with you all and looking forward to a great discussion.
Wonderful. So our standard disclaimer here from myself and Sean. We partner with Medtronics to bring you this live discussion. And this is just some of the edge of our planned agenda. We'll see where the discussion takes us. As you can see, there's a broad range of topics that we will cover today in the next 40 minutes or so, and with some time for questions and answers towards the end. But let's start right at the basics, shall we? Sean, let's start off with you. What's the difference between pain and nociception?
Well, this is a really good question because it's something that we need to distinguish in the operating room. So nociception can be defined as the detection, transduction, and physiological response of a patient to a nauseous stimulus. On the other hand, pain is completely subjective. It is the patient's interpretation of this nauseous stimulus and of this nociceptive response. And pain requires that the patient is conscious. Nociception, on the other hand, happens regardless of if you're conscious or not. Your body reacts to a nauseous stimulus.
Okay, so on that note, one of the key points that you've made is that for pain, you need a conscious patient. So how have we traditionally gone about measuring pain, nociception? What's the traditional way of doing things?
So for pain, the best way is to talk to the patient and ask them. And there are a series of scores we can ask. The numerical rating score is one that's very frequently used. However, in the operating room, in a patient under general anesthesia, it's impossible to discuss with the patient. So what we traditionally use to assess nociception in that case is heart rate and blood pressure. Those are the most frequent indicators. But patient movement can also correspond to nociception, spontaneous respiration as well, increase in airway resistance, sweating. And then there are some monitors like the BIS. A change in frontal EEG signal can give you an idea of inadequate anti-nociception. And the BIS has been around for over 20 years, so quite a few clinicians know how to detect inadequate anti-nociception with this monitor. But traditionally, and what most people really use is heart rate and blood pressure to guide their anti-nociception. And that, unfortunately, is not very sensitive or specific.
Thank you, Sean. And as an anaesthetist, one of the things I worry about most is awareness. And again, the parameters that you've mentioned, heart rate, blood pressure, tearing, to me are also signs of awareness. So it's not just pain. So there's a significant overlap between the clinical parameters that we traditionally use, which also means that it makes it very difficult to treat pain, treat nociception in the OR. Rachel, any comments about that?
Yes, I think that one of the challenges that physicians face is that really heart rate and blood pressure are surrogate measures, and the question is, well, if the heart rate and blood pressure are going up, what does this really mean? Because we know that patients, particularly elder patients, are likely to also suffer from hemodynamic instability, and this could impact their heart rate and blood pressure for completely other reasons. And then a second challenge that we face is that we know that there is tremendous interpatient variability around opioids. And essentially, if we have two patients with a similar profile and undergoing a similar type of surgery, their actual opioid requirement could be very, very different. And the question is, how are we going to know exactly what the correct dosing should be?
And you raise a very, very good point. I think there is, for me, as in my clinical practice, I've noticed a change in a shift in mindset, because I think before, as anesthetists, we're worried about underdosing anesthesia, underdosing analgesia. So we think, right, we're going to give more and more and more anesthesia, more analgesia. And actually what we're finding now is too much anesthetics does patient harm. Too much analgesics, opioids you've mentioned, Rachel, does adverse outcomes to patients, both from a mortality perspective as well as a morbidity perspective. Sean, would you agree with that?
Well, to show that there's a link between mortality and anesthetic death is pretty tough. There have been some studies that have shown that burst suppression is linked to increased mortality, but if you look afterwards at sub-analysis of the B unaware study and the bag recall published in the BGA. So these two articles were in the New England, but then they did a sub-analysis that they published in the BGA in 2014. They weren't able to reproduce this link. Mortality is really hard, but certainly post-operative complications can be linked to overdoses of opioids. I think everybody can agree that if you give too many opioids to a patient, you risk, for example, causing nausea and vomiting, or worse, airway obstruction. And airway obstruction can lead to death. So yeah, I think it's pretty obvious that if you give too many anesthetics, too much opioids, you risk developing complications. I think everybody here would agree on that.
Thanks, Sean. Right. So on to the device itself then. This is a picture of the device. Rachel, can you tell us a bit about the personalized solution proposed here?
Sure, absolutely. Well, as you can see in the picture, the Knoll is a non-invasive monitor, and you can see at the end of the white cable, you can see a red finger probe that is attached to the patient's finger, and there is a single-use sensor that is wrapped around the finger too. And the idea is that by attaching this finger probe with the single-use sensor, the Knoll is actually capturing continuous streams of physiological information from the finger. There are 4 sensors being used. We have a photoplethysmograph, accelerometer, galvanic skin response, and the peripheral temperature. And the idea is that we are capturing essentially physiological streams of information that are reflecting the sympathetic activation. It's really important to note here that the Knoll is actually a multi-parameter index. The idea is that by capturing multi-parameters at once, we will have a much more robust and reliable indication of the actual level of nociception. So we have these continuous streams of physiological information that are being captured by the monitor, and then we have a machine learning algorithm that has been trained on clinical sets of data. It's been trained essentially to distinguish between nociceptive stimuli such as intubation or incision and periods of non-nociception. So the principle of machine learning is essentially you feed an algorithm with some data which has been well classified, and you teach it to distinguish between the positive and the negative, if you will. The monitor then learns these patterns, what we mean by how nociception is characterized, and how periods of rest, of non-nociception, are characterized too. And then essentially it looks at the stream of data it is receiving from the patient and analyzes the patterns, and is then able to determine whether what it is seeing is a pattern that reflects nociception or a pattern that reflects non-nociception. And then the output is a stream of is a scale of 0 to 100 with a numeric value and a trend. And I think the really cool thing here is that this null score is personalized to the patient because it is being normalized to the patient's own data, and it's also normalized against the big database that is already included in the monitor. So then we end up with a scale of 0 to 100, in which 0 means no nociception, 100 means extreme nociception, and it's personalized to the individual patient. And so it's really giving a good indication for that patient when he is essentially at rest, experiencing no nociception, and when he is experiencing a physiological response to nociception. And that will, of course, guide the clinician with treatment.
You've mentioned that it's personalized to the patient. So is the idea that you apply the device on the patient before the start of induction of anesthesia? Is that what you mean?
Well, there is a brief calibration period for the first 30 seconds to 1 minute that the probe is placed on the finger, where it's essentially just creating the basic signal acquisition. But basically, after around 10 minutes, the monitor, the null stream has really become personalized in that it is mostly based on the patient's own data. Initially, it is normalized more to the data that is in that the algorithm and the monitor already include, the database that the monitor has inside. But after several minutes, the algorithm is then looking mostly at the patient's data, although it continues always to use the database as a reference to ground itself to.
It's absolutely fascinating that you've managed to fit all those parameters into such a small single probe that fits on your finger. Going through the different parameters that you've mentioned, is there a particular parameter that's more important than others, or is it just all of it feeds into this algorithm that you've mentioned?
So the photoplethysmograph is the most important parameter, but the galvanic skin response, which is measuring the sweating, is also important too as an indicator of the sympathetic arousal. The peripheral temperature and accelerometer are more like supporting parameters to help the null to correctly reflect the patient's status at all times and adjust to situations that could be changing during anesthesia, and contributing to the overall robustness. I saw that there were a couple of questions that were just coming up on the screen now. So the first one I saw was a question whether the null can also act as an SpO2 monitor, and the answer is no. The null is not an SpO2, is not functioning as an SpO2 monitor, although that question comes because of the photoplethysmograph, but we don't measure both of the wavelengths that would be needed to act as an SpO2 monitor.
Okay. And on the subject of the algorithm, we've also had a comment from, I think it's one of our Twitter followers, who says, how does one train the algorithm to recognize the nociception stimulus without does it need a comparison, or does it need a stimulus to actually train it?
So during the training phase, we had a set of classified data which was reviewed by experts, and experts helped annotate the data to indicate where there was a nociceptive stimulus, such as incision or intubation. Intubation is the most painful stimulus, with incision being also nociceptive but less so when compared to intubation. So essentially, we had a large data set that was annotated by clinicians, Also taking the amount of analgesia on board into account, because obviously if the patient has received adequate analgesia, we would expect the response to incision to be different than to a patient who had absolutely no analgesia on board. So there was a scale created that essentially reflected the expert annotation of the data, and the algorithm was trained on this scale, and then was validated to make sure that the resulting algorithm had a very high level of correlation with this expert-derived scale.
Thank you very much, Rachel, for a comprehensive overview of what the NOLS device actually is. Sean, coming back to you now, you've mentioned the BIS monitor as well. Your thoughts then on BIS and NOLS technologies and monitors? They complement each other?
Of course. So there was a really nice slide earlier where you showed the three components of balanced anesthesia. There's, of course, neuromuscular blockade, but there's also anti-nociception and hypnosis. And these things go together. And if you think about it, you know, the BIS, for example, I mentioned how it can detect inadequate anti-nociception. There's a really nice article, a review that came out in the BGA in February that talks about this. And what they showed is what they review is the different patterns that appear whenever there's inadequate anti-nociception and a nauseous stimulus. And this actually elicits cortical activity that can be measured with frontal EEG. So in other words, if you don't have enough opioids and you start surgery, you'll have cortical arousal. So that's just the BIS showing how this component is also affected by inadequate anti-nociception. On the other hand, you just mentioned it earlier, if you're aware during anesthesia, what's going to happen? You're going to start sweating.
Yeah.
You're going to start moving if you're not paralyzed. You'll have increased heart rate, increased blood pressure. So theoretically, although this hasn't been shown for simply ethical reasons, but if the patient is aware, the neural index would probably increase as well, because there's an increase in autonomic tonus. So are these monitors complementary? Of course, because they guide two distinct components of anesthesia that cover each other and that work together. And by optimizing both components, we're able to give just the right amount of medication to our patients to assure a steady state of anesthesia.
Thanks, Sean. Now, that's all well and good, talking about the various different theories, concepts, and designs, and what have you. Perhaps to illustrate all of this, I believe you've got a couple of cases of when you use NOL to illustrate how useful it is in the OR.
Sure. So let's start with a very simple case. So imagine you have a patient undergoing thyroidectomy, a healthy young patient that unfortunately has papillary cancer of the thyroid and has to have it resected. What I usually do for this type of anesthesia is I use remifentanil and propofol, and then have a transition dose of morphine with some paracetamol and a non-steroidal anti-inflammatory drug at the end. I also assure a little bit of anti-nociception as well as post-operative nausea and vomiting inhibition with dexamethasone. And so imagine with me that we're putting this patient under anesthesia, and we're using pharmacokinetic models such as Schneider and Minto. So we induce the patient with effect site concentrations of 4 and 4. We've got the patient fully monitored with standard ASA monitoring, but also, of course, with the NOL and with the BIS. And the BIS can, of course, guide us to know when we can intubate, whenever it's below 60. And then we intubate. And we notice that there is a change in the NOL, an increase in the NOL, and a little bit of increase in heart rate and blood pressure. So there we could already have a little bit of an idea of the patient's own personal nauseous response to a strong stimulus. And if the NOL rises a lot, it might give us some kind of clue of how much remifentanil would be necessary for incision. So after intubation, however, we're not going to stay with the effect site concentration of 4, or we're not even going to increase. We're going to decrease them because, at least in the center where I've worked predominantly, it takes a little bit of time for the surgeons to get ready to install the patient. And so to maintain a steady state, I usually decrease my effect site concentrations to 3 or 2.5. And so we're waiting, and then about 2 minutes before the surgeon's ready, we're going to modify our anesthesia. Of course, during this half hour or so where we waited, we modified the BIS. We modified the propofol to maintain the BIS and target. But the NOR was always low because there was no nauseous stimulus. So one utility, like I said, with the NOR would be to have a good remifentanil target for incision so that we don't have a strong nauseous response that elicits a cortical arousal, right? So since this patient did respond at the NOR at intubation, we set the effect site concentration at 6 instead of 4, 2 minutes before the incision, and the surgeon starts. And what do we have? We have maybe a little bit of increase in the NOR because it was below 10 at that moment. But since we anticipated the surgical incision and we had already evaluated the patient's response at intubation, there's no big change. So in this simple case, we continue the anesthesia. We maintain a steady state anesthesia and can continuously, for example, every 3 minutes, modify the propofol infusion and modify the remifentanil infusion to remain in target. Half an hour before the end of surgery, we administer the morphine, the ibuprofen, and the paracetamol. And then, whenever the surgeon's done with the bandages, the patient wakes up quite quickly and is completely capable of telling you her date of birth, for example. So this is an example of a type of anesthesia that I learned with some very, very outstanding professors. And it just shows how you're able to have a patient completely asleep, completely in a coma, actually, and capable of waking up quickly and getting up without any pain, and the hours that follow anesthesia. Now, another example would be adding dexmedetomidine to this. Mm-hmm. So this is something that I actively investigated with colleagues, and what we see when we add dexmedetomidine as a continuous infusion is that both the NOR and the BIS are able to tell us that there is some kind of effect of this third medication on both hypnotic depth and anti-nociception. And actually, if you were to do the same case, but you add dexmedetomidine, we'd be able to decrease the effect site concentrations of both propofol and remifentanil to significantly lower concentrations that maybe some would not feel comfortable doing if they didn't have these monitors. If they didn't have the BIS, they would probably stay around 3 effect site concentration, 3.5. But with the extra effect of dexmedetomidine, you could decrease, for example, to 2.5 your propofol effect site concentration. And the remifentanil can also be decreased if you use the NOR. And if you decide to do multimodal without an EEG monitoring and without a NOR, mm-hmm. you might end up having actually excessive amounts of anesthesia and provoking burst suppression, mm-hmm. which I think a lot of people can agree is not the intended goal in a thyroid operation. So those are two pretty simple cases where the main anti-nociceptive drug is remifentanil, and how it can be easily titrated by keeping the NOR values between 10 and 25.
Okay.
So thank you very much. Yeah.
I was going to ask Rachel to come and chime in on this, because you've mentioned the numbers and an index before, and when you introduced the NOR device earlier, Rachel. And Sean, you've just mentioned the number 25. We've got a nice slide here. Rachel, could you take us through what the numbers mean?
Sure. So once we have a monitor that is validated, the next question, of course, obviously is, well, how are we going to use it to help patients? I mean, there's no point in having a monitor out there that just shows numbers and without eliciting any response from clinicians. So a tremendously important part is figuring out how the device should be actually used in clinical practice to guide care. And we invested a lot of effort in that, working with some early adopters, in particular with Professor Albert Dahan of Leiden University and his team, on really working out the thresholds that should be used to guide clinical use. And we did some early outcome studies with Professor Dahan and his team around this threshold of 25, and we also validated this threshold of 25 by looking at a very large data set. And I keep speaking about data because obviously we have an AI technology here, and everything depends, of course, on the quality of data that we have. So we analysed a very large data set of cases that had null monitoring. And we looked at the best point. We did an ROC type analysis and looked at the best point that would best represent the transition between areas in which there was a nociceptive response and areas in which we could say were in a situation of nociception, anti-nociception balance. And the statistical method to do that is using the Udin index, and the results were indeed that 25 appears to be the best threshold distinguishing between nociception and a state of nociception, anti-nociception balance. So if the null is above 25 for at least 60 seconds, that could suggest excessive nociception, and the clinician should indeed consider how to treat that. It's really important to note that the null is an adjunct monitor. It never replaces the clinical judgment of the clinician. The clinician needs to consider the needs of the patient and needs to consider what the other monitors are telling him too. But certainly we think the null can add some important pointers. So if the null is above 25, that suggests that the patient is experiencing nociception and it should be treated. Between 10 and 25, that is the range of nociception, anti-nociception balance. That's the ideal range, the target range where we wish to be. Particularly with remifentanil. Remifentanil is easy to titrate, and it's feasible to keep patients between 10 and 25. Particularly when working with Tiva TCI, and Professor Dahan and his team were able to show that. And particularly with remifentanil, if the null values are below 10, in the absence of noxious stimulus, that could suggest that there is actually excessive opioid on board or other analgesic agents on board. And that could be a prompt to the clinician to think about tapering off some of the analgesia. I would like to also put out there that it's never a good idea to shut down the analgesia completely, even if the null is very low. We must always keep some analgesia on board, of course, because the surgeon could perform a painful manipulation a minute or two later, and then, of course, when we do, we should never be with zero analgesia, because then there will be nothing on board. But
that's a very good
what
point.
we were able to show is that, Sean, yeah.
Yeah, I just wanted to just add on this, because this is kind of a trap if you're not careful. You can't forget that the null is a reactive algorithm. It doesn't tell you about what the surgeon's about to do. That's your job as an anesthesiologist to know that he's going to incise or do sternotomy or whatever he's going to do. You need to know what he's going to do ahead of time. So if you're using the null and you're saying, okay, yeah, I'm waiting, everything's fine, there's not a lot of stimulation, you cut your remifentanil down to a very low concentration, and then the surgeon stimulates, don't expect the patient not to react.
Very good point.
Rachel was 100%
Exactly.
right on this. You need to keep some kind of anti-nociception, and you need to make sure to know what your surgeon's going to do. Or else you're going to be disappointed in the null, because the patient will react.
Very nice tip there, Rachel. So it looks like the message is that 25 seems to be a magic number. But coming back to what you've mentioned about what you've observed with dexmedetomidine, Sean, Prof. Holmes there has mentioned that a similar effect is seen in his experience with clonidine, the propofol remifentanil anesthetic there as well. I believe you got a third case to illustrate how you use the null, Sean.
Yeah. So I have a case this time that's maybe a little bit more complicated. It's a patient that comes from the ICU, still relatively young, in his 40s, Fortunately, he developed pancreatitis, and he's got necrotic cysts that need to be taken care of because he's developing an acute abdomen. And it's so severe actually that he's under norepinephrine at a dose, for example, of 0.3 micrograms kilograms minute. But he's also intubated. He's got continuous midazolam at 5 milligrams per hour, continuous propofol at, for example, 8 milligrams per kilogram hour, and a sufentanil infusion of 0.3 micrograms kilograms hour. So quite a high dose of anesthesia and anti-nociception in a patient that's developing this acute abdomen. And so the numbers might not be 100% correct because I don't remember them by heart, but the numbers are roughly that. Huh? So I go get this patient in the ICU and I bring him up to our OR, and there my usual reflex is to put a little bit of sevoflurane, an inhaled ether, whenever I transfer patients from the ICU because they're already intubated, and my reflex as an anesthesiologist is to give anesthesia, right?
Yeah.
So I do that, and I put the BIS and I put the NOL while we're monitoring after I've made sure that my hemodynamics are well and the patient is installed correctly. These aren't the dominating monitors that I use, but they're important monitors. And what do I notice? I notice that the burst suppression ratio is around 50. I also notice that the NOL is almost non-existent, between 0 and 5, barely fluctuating. And so I tell myself, well, this patient has had way too much midazolam. Now, you need to keep in mind that it's not that simple, though, because a lot of intensive care patients have burst suppression for different reasons. But seeing that the patient is young and the problem is not neurological per se, but abdominal, I allow myself to stop the midazolam, and I stop also my inhaled ether, and I decide from now on I'm going to titrate the propofol based on the BIS, right? And for the sufentanil, I wait. I wait because the surgeon hasn't started yet. And like I said, if you don't have any nauseous stimulus, don't expect the NOL to be high. But when the surgeon starts operating, there's no change in the NOL. It stays very low. So what I did during this case is I was able to titrate the propofol to increase my BIS, which was really low. It was probably around, I think it started around 15 or 10. I get it to the range of 40 and 60, but I'm never able to get rid of this burst suppression. And the NOL slowly increases as I decrease every 15 minutes or so the sufentanil concentration. And I was able to actually halve the sufentanil, get rid of the midazolam, and decrease my norepinephrine substantially, probably to something like 0.1 micrograms kilograms a minute. And so for me, using the combination of BIS and NOL in that situation actually allowed me to tune up the patient's anesthesia as he stopped by the OR during his ICU stay. So not only did the surgeon certainly help in the acute abdomen, and I'm not saying that he had no impact on the norepinephrine drip, because by solving the surgical problem, it probably helped. But I think also by decreasing substantially the anesthesia to levels that remain therapeutic was also quite useful. And I would not have done that without a BIS or without a NOL. Without a NOL, I would have maintained my sufentanil at the same infusion rate. And without a BIS, I would have had my inhaled ether at a MAC of about 0.6. Maybe a little bit less, depending on the hemodynamics.
Very interesting, Sean. Do you happen to know what happened to the patient after when you deposited the patient back on ITU in terms of what the sedation analgesia that they use by your intensive care colleagues?
Yeah.
Curious, isn't it?
Yeah, what did they do? They didn't use a BIS and they didn't use a NOL. That I know. And yeah, I don't know. I can't tell you. I can't tell you.
Thank you very much, Sean, for sharing those cases. we've gone through the science behind the null, and Sean, Rachel, you shared with us some clinical tips and gems about how to use the null. Moving forward, then, one of the difficult things is that the null is a relatively new technology. So there's always a degree of apprehension, trepidation, so on and so forth. So, Rachel, have you got any top tips to share in terms of someone who is listening or colleagues who have been heard of the null in terms of how to perhaps integrate it into their practice or introduce it into their department? Any tips there?
Absolutely, Adrian. So, first of all, I would like to start by saying that I really don't think that the null is a difficult monitor to use. It's pretty intuitive once you get trained. There's a scale, as we discussed, there's a scale of 0 to 100, and 25 seems to be a clinically relevant threshold. I think that we need to approach this just like we approach typical change management processes whenever we're introducing something new into the hospital. So I'd like to start by saying that we need to understand that no patient monitor is going to improve outcomes by itself.
Couldn't agree more.
The patient monitors will only improve outcomes if the clinician responds and if the clinicians do something when they see something on the monitor. So first of all, the collaboration with the clinical community is tremendously important to us, because if we want to introduce a new technology, it's not enough just to bring it to the market and explain the buttonology. We need to be able to develop the clinical implementation guidance with the early adopters of the technology, and that's what we've been working on in the last couple of years. And I think that we pretty much have that now. We have multiple publications and materials that we can provide to clinicians who are learning to work with null. But to keep it really simple, I would say that when we want to introduce the technology, I would say, first of all, let's get together as a group. Let's speak to all of the stakeholders and agree on what it is we're trying to do. Why are we using null? Why are we trying to introduce null? And understand with the clinical team what the clinical challenges that they're facing that they want to see addressed. So that would be point number one for me. Why? Why would you want to use null? What is it that you're seeking to improve? Then the next thing is, how are we going to use null? Which patients are we going to use it on? How are we going to do it? Who is going to do it? Make a plan for the evaluation, and always start by first just observing it. Don't try to immediately intervene according to the null. First of all, when you've got a new monitor, first of all, just watch it. Just have it running there and observe. Gain some confidence. Just see if you believe it, if you see that it is related to what is happening during the course of surgery. And then have a plan about how to run the evaluation. So which patients are you going to be evaluating it on? In which anaesthetic regimens? What are the metrics that we're interested in looking at? Are we interested in intraoperative consumption, or are we more interested in post-operative metrics? We haven't really spoken about this, but when we think about why are we using null, the idea is that by providing smoother and more balanced anesthesia and analgesia that is tailored to the patient's needs, the patient will then recover well from anesthesia and wake up in the PACU with less pain scores, with less post-operative nausea and vomiting, and so on, and overall experience a better recovery with less experience of with reduced post-operative pain in the PACU. That is, of course, in the big studies, is associated with less chronic pain too. Overall, to be on a better trajectory towards recovery. So, to summarize, I would say, first of all, we need to understand that no patient monitor will improve anything unless there is a clinical implementation guidance on how to respond to it. That's point number one. Point number two is gather the clinicians. Agree on what the goals of the evaluation are, agree on why we're trying to evaluate null, what problem we're looking for it to help us with, agree on the metrics, and observe it a bit before actually responding according to the guidance we were speaking about a few minutes ago. And of course, from our perspective, it's really important to listen and to learn and to interact. It's I think that when we bring meaningful innovation to the market, the manufacturer can't do it alone. The manufacturer depends on working closely with the clinical community so that we can work together to improve patient outcomes.
Thank you very much, Rachel. I'm going to ask Sean for his top tips in a short while, but just a quick mention to our viewers that if you've got any questions that you want to ask our experts for us to discuss, if you put them in the comments chat, we will do our best to get through your questions fairly soon after this. I think just from my perspective, Rachel, a couple of things that you said really resonated with me, which is the idea that you can be more precise and yet individualized, personalized analgesia to the patient using the device, and that's a concept that I think really appeals to me. Sean, as a user of the NOLs, any top tips of how you've managed to transition from trying it out to integrating into clinical practice and in your department?
Of course. I just want to highlight what Rachel said, that compliance to protocol is essential. If you want to be able to personalize anti-nociception using the NOL, you need to follow the instructions. You need to be able to maintain the NOL between 10 and 25. Simply just putting it isn't going to solve anything. I mean, we've seen this, with goal-directed hemodynamic therapy. You could put the monitors, but if you don't follow the goal-directed protocols, you won't have an impact on fluids or on post-operative outcome. So it's the same thing with the NOL. If you want to have an impact on your patient's hemodynamics, for example, and decrease the incidence of hypotension, like the Meyer study in anesthesiology showed, you need to have a good compliance to the protocol. So that's really important. And again, nobody said this better than Michael Pinsky when he was talking about goal-directed hemodynamic therapy. No monitor has an impact on outcome. It's the strategy associated with this monitor that has an impact. So that's what Rachel said, and I think that's a very important point that needs to be clear. The second one on a tip or tricks using the NOL, I think the first thing that you should do is you should give it a try. You should get a few electrodes and have a patient in whom you think it could be useful. Even if it's a thyroidectomy, put it on the patient, couple it with the BIS. And maybe the first time, just do anesthesia like you would do without it, okay? Do anesthesia as if you weren't compliant to the protocol. Do anesthesia like you usually do it and look at the values. See if you think they're logical. And perhaps you'll see that maybe you give a little bit too much anti-nociception and anesthesia. And then the next time, give it a try. Give it a try and follow the protocol. Get that NOL between 10 and 25 and that BIS between 40 and 60. Avoid burst suppression. And make sure to anticipate what the surgeon does. Don't expect that the patient will be calm and stable and will not have any cortical activity if you let the surgeon incise at low concentrations of propofol and remifentanil. So anticipate as well. This is a really important tip. I've already said it, but I'll say it again. These monitors are reactive. They assess different parameters and give you a number. It's a reactive number. There's no prediction whatsoever. You need to be able to anticipate, and if you know that there will be a nauseous stimulus, if you know that the patient might feel something, you need to increase your doses of medication and then titrate down once it has happened. So I guess those are the main tips. And if you do this, you might just be able to see for yourself the benefits of personalizing anesthesia depth in anti-nociception.
Thank you very much, Sean and Rachel. We're now moving on to a bit of question and answers there. I've been reliably informed that a lot of the studies references that Sean and Rachel have mentioned in this discussion will be available on the website, Medtronic website. The link is shown there. On to a couple of questions then. Rachel, if you take this one, a colleague from Giovanni mentioned when you put the probe on, do you put it on 10 before induction, after induction? If it goes on, how long would you recommend having the probe on for prior to theatre and incision?
What I mentioned before about the 10 minutes was just about the the balance about how long it takes the algorithm to fully learn the patient's patterns. But normally we put the sensor on immediately before or immediately after induction. It's not that important if you put it on, say, 30 seconds before induction or 30 seconds after induction. What we would expect to see at the beginning is high null values, and then after induction, of course, we expect to see the null to fall and to fall into the range we were talking about, around between 10 and 25. And then once we see the intubation, we expect to see the null go up. Just before induction is completely fine. And then, as I was saying, it takes a few minutes for the readings to be fully normalized to the patient. But that doesn't mean that the readings before are not valid. It just means that they are more based on the big data than on the patient's own profile. It's just a process over time. But the null can be totally relied on as soon as we see a value posted on the screen, which is typically around 30 seconds. And I saw another question there about post-operative delirium and opioids.
Mm-hmm. Yep.
So we've seen that the excessive opioids, and particularly when combined with excessive hypnotics, can contribute to post-operative delirium in the big studies. But we haven't got such data yet with the use of null monitoring. That will depend probably on larger size registries to be able to see that.
Okay. Sean, this is a question for you then. This came from a follower from Twitter, which is, do you routinely use null for all your cases or select cases? And if not all, which are the ones you do select for and which ones you don't tend to use null for?
Yeah. So I don't use null all the time, it's true. But it's more a question of access and of costs for the moment. But I think there are some patients that could definitely benefit more from personalized care than others. And I think what I would just want to touch on what Rachel just said about delirium. I think that we can't just think that one component of anesthesia is going to allow us to solve a problem as complex as delirium. I think we need to really think about personalizing all our care, using blood pressure targets that are close to the patient's baseline pressure, making sure that the hypnotic component doesn't induce burst suppression, and giving just the right amount of opioids to maintain the null stable. That, together with personalized fluids and ventilation, might allow us to improve outcome. But just focusing on one component, I think is hard. And this is really, it comes back to what I was saying earlier. It's important to see that these monitors, like the BIS and the null, are complementary to one another. Now, what patients do I think would benefit more from the null? I think those are the patients that would benefit the most from a personalized anesthesia. You know, the frail patients that are elderly, that have that are prone to develop burst suppression. You know, if you give too much opioids, you're just going to amplify the hypnotic component. You know, there's a study in Anesthesia and Analgesia that's either out or it's going to come out soon, where they showed a DAR score. You know, when you have a low MAC and a low BIS, they have this score that can predict delirium. So if you have a patient that you think is at risk of having a frail brain, I think that's the patient you should put that monitor on, so that you make sure that you personalize the components, give them just what they need, and maintain their physiology as close as you can without inducing the side effects of our anesthetics and our opioids.
Thank you very much, Sean. Rachel, from a technological perspective and a device perspective, is there a group of patients that you can't use null on?
Well, so far we do not recommend using the technology on patients suffering from severe heart rhythm problems. because we're worried that it could impact the photoplethysmograph signal that the null is seeing essentially. We were not quite sure about patients receiving chronic beta blockers as part of their care, but recently there was a study published by Professor Philippe Richebet and his team in Montreal, Canada, where they looked at a cohort of patients who were receiving chronic beta blocker therapy and compared it to other patients who were undergoing similar procedures under general anesthesia, of course, who were not requiring chronic beta blockers. And actually, they found that the performance of null was equally good. The ROC curves were very similar, so that was encouraging for us because we weren't quite sure about that. So I would say it's mostly these patients with the cardiac rhythm challenges, and of course, if the patient has extreme perfusion problems, then if there is no plus signal, then obviously you're not going to be able to monitor them with null. But I think that if the patient has such perfusion problems that it's impossible to monitor him with null, then there are probably other issues that would need to be this patient would need care for.
Okay, thank you, Rachel. An interesting question from a colleague. How does the null work in patients not under general anesthetic episodes? Example, the ICU patient whose sedation is being weaned. Could you use null for that to target the pain component?
Great question. So we have started doing work in the ICU, partnering with several hospitals, and other hospitals have been doing independent studies using null in mechanically ventilated patients in an ICU setting. So initially we tried to focus mostly on the patients who are deeply sedated. These patients typically also get a continuous infusion of opioids. And we see that the null is behaving quite similarly to how it is in the operating room. We are planning more work in this area. We've also done some early work with COVID-19 patients. And with COVID-19 patients too, we see that the null was behaving as we would expect. So in general, in the patients who were heavily sedated and receiving large dosage of opioids, the null value was kept low. In the patient who is agitated, who is not adequately managed, we see that the null values are high. And obviously in the ICU too, we want the patients to be dosed adequately. We want them to be not too deep and not too low, because if the analgesia is inadequate, they could become agitated, and then they could develop patient ventilator asynchrony, which is obviously a potentially fatal complication. And if the patients are receiving excessive opioids, then they could become difficult to wean. So far our work there has been more observational, but certainly we are looking to develop the clinical implementation protocols there too, just like the work we have been doing with clinicians in the operating room. We also have some initial work that we're doing in patients who are not sedated at all. But this is very initial, but it's part of our roadmap, because our roadmap is our roadmap is based around our mission, and our mission is essentially to help prevent patients suffering from pain and the effects of pain-related medication. So obviously we start in the operating room, we continue to the ICU, but our vision is to help all of these patients suffering from pain.
Thank you very much, Rachel. Building on what you've mentioned on the ICU patient, one of the more challenging groups of patients that certainly as an anesthetist I have to deal with is the polytrauma patients who's had unfortunately been involved in road traffic collisions. They've got broken bones, abdominal injuries, so on and so forth, and they're young as well. Now, unfortunately, they might have an element of a brain injury on top of it. Have you got any data, either Rachel or Sean, or experience to deal with that group of patients? Because analgesia is, I think we're all acknowledging that group of patients is challenging.
So
we haven't run any studies there yet.
I think Rachel said it best. You know, with really acute problems, polytrauma, The patient has other problems that need to be managed as a priority before we start optimizing anti-nociception. I think perhaps later, whenever the traumatic brain injury has been taken into consideration, when the appropriate perfusion pressure has been determined for the brain, and we operate the patient a day later for the hip fracture, it could be useful. In the acute setting, I would not focus on the null. Maybe the BIS could help. If you see burst suppression even before you increase your anesthesia, you can know that perhaps the patient is at high risk of mortality, because burst suppression in intensive care unit patients has been shown to be linked to increased mortality. So there are interests in using both of these monitors, but for the anti-nociceptive component, I'd be focused on way too many other issues than that in the acute setting.
Thanks, Sean. Probably going to be the last question of the evening. I think Rachel's probably best placed to answer this one. How do we use the null if we had a patient without a hand or suffering from diabetic peripheral neuropathy? Could you put it on the toes?
Well, first of all, if we can't place the probe on one finger, then maybe there would be another finger available.
There are, yes.
I haven't seen yet patients monitored on the toes, except for one anecdotal example of a young child. But we haven't studied placing the finger probe on other areas of the body. Normally, what we do see is that if there is, for some reason, some particular sensing issue with a particular finger, normally what we do is just move it to another finger, and then normally the issue self-resolves.
Okay. Hang on. Which kind of surgical event do you use to train the algorithm? Does it matter whether it's incision or manipulation of a broken fracture or anything like that?
Yes, it does, actually, because I mentioned before that we developed this expert scale where we had the expert assessment of the level of the nociceptive stimulus and considering the level of analgesia on board, because we can't look at the nociception alone. We have to take the amount of opioid on board as well when deciding the overall nociception level of the patient. So yes, we used different types of events. So we had incision, we had intubation, we had surgical manipulation, we had trocar insertion, all kinds of events that were annotated when the data was being recorded, and we had the expert input to help grade the level of the stimulus.
Fantastic. Our time is actually nearly up then, and last one, because Yasmin keeps flagging it up. Are either of you aware of medical legal cases where null has been useful? And I suppose as a closing comment, where do you see the future of nulls heading?
I'm not aware of medical legal cases yet, but we see, as I mentioned before, our vision is to help all patients. So we want to help all patients, and by preventing suffering from pain and from the effects of pain medication. So we start in the operating room, and what Sean mentioned about for instance, frail patients or patients with multimodal anesthesia, or chronic pain patients are another very interesting group, because they're going to be desensitized to opioids, and it's not clear how to dose them. But certainly beyond the OR, we expect to be helping patients in the PACU and in the ICU, both the medical patients and the surgical patients and the COVID patients. There's also the question of the autonomous balance. For instance, one of the phenomena that is reported with long COVID patients is dysautonomy of the autonomic nervous system. So that's another point where null could help, because null can also tell us if the balance between the sympathetic and parasympathetic nervous system is normal or is not. So there's a lot more to do, and it depends on engaging with the clinical community and innovating meaningfully together.
Sean, closing comments?
Yeah, so I think it's a very interesting question, and it makes me think of a friend of mine who's working in a chronic pain unit, and he's also a consultant for medical legal issues, concerning chronic pain. And he asked me once, is there a monitor that we could place on a patient's finger and see if he really has pain? And if Medicens and Medtronic are able to show this, I think we could go even further than the ICU and the PACU and go into chronic pain, because there, maybe this is what the attendee is alluding to. There's a lot of potential utility for a monitor that can really assess the patient's pain when he's suffering or she's suffering from chronic issues. So far as I know, there's been no medical or legal utility of the null index, but maybe in the future.
Okay. Yeah. All right. Thank you very much, Sean, Rachel, for sharing your expertise, knowledge, and thoughts on what a very interesting device. Thank you, everyone who's been tuning in, for your questions and interaction. As a closing statement, all the references, like I said, and resources are available on the link shown there. There's a quick guide, user guide there, which I found very, very useful to look through. So thank you very much, and have a good evening or morning, wherever you are.
Thank you.
Thanks a lot, Adrian, and thanks, Rachel.
Thank you very much.